welcome to all our Mastermind members to another episode of Table Talk, the Care Provider Solution Show, where we do our best to encourage and enlighten some of the most amazing people in the world, we think, adult foster care home owners and managers. Today we have Busch from Trinity Health Hospice and Angelyth Marino from Hearthstone Hospice and Community Assisted Living. And we're going to talk about demystifying hospice in your AFC, how it affects you, how you can use it. It's an amazing tool. So, of course, our very own coach here at Care Provider Solutions, Nadine Carlson, will start the discussion.
I'm so glad you guys are here today because when someone hears the term hospice, sometimes, very often, the thought will come to mind, oh, I could never consider that. I would never let my residents down. Or maybe they take care of a younger population, so they would dismiss it. I don't need to know about hospice. What's the possibility of even having to consider it? But what's really interesting about the topic is there's so many myths associated with it. And because you two are experts in this field, I'd like you to help us understand what are some of those myths and how is it that you're not letting your residents down if the situation is appropriate, and discuss so that there's no more confusion about that, and ultimately the residents get the better care and can age in place if that's the desire of the home. So let's go ahead and start with that. Let's talk about the myths and the truths, and then we'll go ahead and open the discussion further.
Alrighty, great. I think that this is so important because in my experience, AFCs are a very close, tight-knit family setting with the caregivers that are very involved, very close with their residents. And they feel like hospice is more like you're giving up, or, this is the end all be all. So I think that this is great. So thank you so much for having us today, first of all.
Thank you so much for having us today. That's wonderful to be here to share and communicate to everybody how wonderful actually hospice is for residents.
I think the first myth that we could talk about is the fact that hospice is very expensive, when in actuality, hospice is a 100% covered Medicaid benefit.
That's right.
And this not only includes the services that we provide physically with our patients, but it also includes the medical equipment that they need, hospital beds, oxygen, over-the-bed tables, wheelchairs,
Incontinence supplies, wound care supplies that are very important towards the end.
Gloves, wipes, briefs, and then also all of the medication that is related to their hospice diagnosis.
So those can add up real quick.
They sure can.
Amazing.
Yes.
Another myth that we hear, is that hospice kills people.
Oh, that is so not true. And there are so many medications that are provided within the comfort care package. And that includes morphine, that includes Ativan, Heldo, and there's so many other comfort meds. But the one that is feared the most, and I experienced that in the assisted living, is the morphine. Caregivers, families are afraid to actually give morphine to a patient that actually needs it for comfort. And it's a lot of education that takes in for them to actually feel that they're doing the best they can to provide that comfort to the patient. But it's the most feared medication. And
Absolutely.
I know your expertise will say the same
What
thing.
is it? Yeah.
Absolutely. So morphine, the type of morphine that we are giving is actually called Roxanol. It's a liquid morphine concentrate. And the milligrams on this morphine, and I am also a nurse, is not the same concentrate to where if you were to fall off a curb and break your leg and they give you 5 milligrams of morphine in the ambulance, it is not the same way that your body is absorbing it because it's oral. So it is just a little tiny bit of liquid that you swallow, or if you're not coherent enough to swallow, is put in your cheek for absorption. It has to go through your digestive tract. It's not morphine that is being put through an IV or into your muscle as an intramuscular injection. This morphine, it's just carried differently throughout the body, so it's not the same. You're not comparing 5 milligrams of Roxanol versus 5 milligrams of IM or IV morphine. And so a lot of times we really have to explain that this is almost like microdosing, like pediatric doses of morphine.
That's really fascinating. But then how do we get beyond the feeling that you're letting your resident down when you're noticing a decline? And we'll talk about when it seems to make most sense to start considering it. But how do you pass that myth?
A lot of education. Education is the key. The hospice team has the case manager, which is the nurse, that is going to be going to the homes and explaining the team what is morphine for, when it's appropriate to be given. And morphine, it's for comfort, is for shortness of breath or for pain. That's when it's being used the most. And that's where the hospice team will be there to support you and teach you when it's appropriate to use it.
Yeah, I think that's probably one of the hardest things in the ASC environment is, but when to give it. But, us as a hospice team, we understand that the people that are working in, AFCs, assisted livings, they're not nurses. So we know that, and that's okay. Even if someone is at home, their wife or son, they're not nurses either. So we know that, and that's okay. But we want to educate them on what to look for, what signs, that they might need. And a lot of times, I don't know if you guys do this, but what we do is if we see someone that is really struggling with shortness of breath or pain, we actually schedule,
The morphine.
Yeah. We do that just because we're then giving that order to administer. And I think that it gives the person administering a little bit more confidence.
Right. That they don't have to
Make that
decision pretty
Yes.
much, because that's at the end of the topic, or at the end of this, like they're feeling that they're the ones making the decision on when to give it, and then, oh my goodness, am I going to kill this patient by administering this morphine, which is not the case. Like what we explain to our caregivers in our assisted livings is, this patient is here because their body started shutting down. Their body started changing towards that transitionally part of life. And we're here to support them, to actually help them go through that transition. And the question that I tell them often is like, if that was you, would you rather be in pain, suffering, uncomfortable, or would you rather have a peaceful transition when you're not in pain and you're just comfortable? So I always tell our caregivers that that's what we have to watch, that's what we have to see. What is what we want for us? So let's provide that to that person.
Yeah, I love that. So in a sense, the hospice becomes part of the adult foster care team to walk alongside together to give the resident the best support. So Maria, you had mentioned shortness of breath. So that would be one sign that potentially someone might qualify for some type of support, whether it's palliative care or hospice care. So why don't we talk about that next? What are some of these symptoms like shortness of breath where it might be time to bring in an expert to evaluate to see if maybe it's time to have that extra team support come on board?
Absolutely. And it doesn't cost anything to have us come out and do an evaluation. It doesn't, cost the family or the patient or, anyone anything. We don't even have to have an order just from a doctor just to even go talk to someone to see, if they would be eligible for palliative care or for hospice. Those conversations can happen at any time. Some of the things that we look for in someone is any functional decline. I think that is probably one of the biggest things. Okay. So if you have someone that has not needed any assistance with their, what we call activities of daily living, like getting dressed, brushing their teeth, eating independently, ambulating around. If they were independent doing that, or maybe even with one assist like 3 or 6 months ago, and now you notice, wow, they're moving really slowly. They might actually need a walker or maybe a wheelchair. Or, I feel like this person, they're getting up to go to the bathroom and they're coming back and they're short of breath. And that it wasn't the case, 3 or 6 months ago. Those functional declines are really something that we can kind of key in on. And also someone that's sleeping a lot.
Sleeping more than living?
Yes.
Say that again. That's interesting.
Sleeping more than living.
Yes.
Or resting more than living. So taking more naps, just sleeping most of the day and not enjoying life, which is what we should be doing. Yeah.
Someone that wakes up to maybe eat and then goes right back to sleep. Okay. Or even if they're up in a chair, but you find them napping most of the day.
Interesting.
And also the frequent falls, because that is something that happens when they're living independent, like, oh, my loved one is falling more often. And that is even before they move to an assisted living home or an assisted living. It's the constant falling, like they just went to the bathroom and they fell, or they just came to the kitchen and they fell. So what's going on in there? Why are those falls repeatedly happening, which end up them going to the hospital constantly?
Yes.
So that sometimes in this case of repeated falls, immediately in my mind, hospice wouldn't be the first thing I would think of. I would think of PTOT. So how do you differentiate a fall for that would be more appropriate for physical therapy versus calling in one of your team and saying maybe we need to evaluate hospice?
I think it really depends on their cognitive ability also, because in a lot of cases, someone that is maybe confused, they are not able to follow PTOT. They're not able to follow what the therapist is asking them to do.
They're not able to follow directions at all.
Exactly. And a lot of times, these people, they don't want to keep going back to the hospital. And I know from experience too that in order to have someone that may be in that situation at an AFC or AL, in order to not have to send them out, they need to be on
hospice care.
Yeah.
And most of the time, families do not want them to be constantly going to the hospital. The reason why is when they go to the hospital, they often get more confused. They stop eating even more. So if they were, let's say, having less meals at home or having decreased appetite at home, when they go to the hospital and it's a total different scenario from where they were, they stop eating. And then the other factor I would think is the wounds. So when they go to the hospital, they often also come back home with wounds or even C. diff. I have seen that. In my homes, like we had residents that have gone to the hospital because they had a UTI and then they ended up coming with a C. diff infection in the stool.
The antibiotics and the germs in the hospital.
Yes. So families will try to avoid that as much as possible, and residents that have choice or that can make a choice will absolutely refuse to go to the hospital. So they're like, keep me at home. I want to do it here. Bring the doctor. And then that's when we have this conversation with the family. Hey, let's explore hospice, because hospice is not about just dying, but like also shifting the focus on how we view things and the holistic care that they're able to provide.
Yeah,
And let's
absolutely.
talk about that perspective, because often that perspective is hospice, I'm about to die. You know, hospice equals I'm about to die versus hospice equals give me the definition.
Quality of life.
Yep. Quality of life over quantity. But also looking at every piece as to see how can we improve quality of life. So, you know, for example, if someone is on, you know, calcium supplements that are this big, you know, is that really like, and they hate taking it, you know, like it's getting stuck in their throat or, you know, it's like, okay, why don't we take a look at what medication you're on and see if some of these non-essential medications, if they're causing you more grief to try and take them, let's discontinue them. You know, and also looking at what your day-to-day looks like. And if we can, you know, do something, a lot of times for cancer patients, you know, they're extremely fatigued. So what if we did a little steroid? You know, what if we did something to kind of boost your energy?
Right.
You know, it's not going to cure anything, but it's going to help you live your life. It's going to help you spend time with your family where you have more alert hours. You know, symptom management, you know, that's to make them feel the best they can to experience things.
So instead of a negative, hospice is definitely a positive.
Absolutely. We have a gentleman right now who is 103.
Oh, wonderful.
And he just traveled this past weekend to a veteran, you know, like a World War II veteran gathering ceremony, you know, type thing. And we do travel contracts with other hospices. We've had people that go to Florida for the summer or for the winter.
Really?
And we will, you know, set them up with hospice down there. Or if we have someone going up to the, you know, like Traverse City, everyone wants to go up north in the Michigan summer, we actually have travel contracts with our northern Michigan agencies so that during, you know, a set period of time, they're kind of the ones that are on call for our patients.
great.
So that's
Very
a really
nice.
good example of how you can continue to live your life. You're
Yes.
not jailing yourself to
Exactly.
be within the four walls until the time comes that you leave this earth.
Absolutely.
You have the ability in the holidays or during the way you live your life, if you're moving from one place to another
Yep.
for different seasons or visiting family, you can make arrangements with other hospices in those areas.
That's
Absolutely.
right. And then your hospice team is going to be able to facilitate that for you.
Yep.
That's why you have your social worker, and then that's the person that is going to be helping you out through that process.
I love that.
Yeah.
And then emotionally, though, there's still, I think, that tinge inside the heart of a caregiver that they get in that quandary of, am I really letting this person down? So how can we help people get beyond that so they don't feel so, what would you say the word is?
Where the caregiver doesn't feel responsible for making
Yeah.
that decision.
I would say it's almost like a guilt, like they feel
it's a-
like
Right.
a guilt.
Yeah.
And you know, I usually sit down with the whole team around a table like this, and we literally just hash it out and we talk. And I usually always give each of them one of these.
Tell us about that.
This is Gone From My Sight by Barbara Carnes. She has been a hospice nurse for over 40 years. She has actually stepped up her social media game within the last year and a half. She has a newsletter that goes out, and she is on every single social media platform now that you could think of.
Oh, very nice.
Yes, and she wrote this. The original copyright is 1986.
Wow.
Updated this year, but it really goes through step by step the dying process. And this is written in a 5th grade reading level with large print, you know, for people that have any type of eye deficit also. and it's written in a way that is very relatable and very understandable. And it just goes right through 1 to 3 months prior to death. And then it goes, from months to weeks to days to hours. And this is really what I go through with not only caregivers, but families. Because I can tell them these things, but to actually see it in print, it's almost like a checklist. And then those caregivers, it kind of sinks in like, oh my gosh, yes, I'm seeing all of these things. This makes sense now.
It's very predictable, isn't it?
It is.
Yes.
It is. I always say people do not die like they do in the movies. And that's actually Barbara Carnes has a T-shirt now that says that I'm on board for, and because it's so true.
It is.
And it can be very scary. Yes. So this book is kind of like the gold standard in that area. And like I said, I give it to caregivers and I say, just keep this with you, throughout your career.
We'll make sure the information is on the screen for people to order that. Is that free to people, or
No, but it's a very nominal
a
fee.
donation? Or?
She has other books also.
They have the different color books.
Yes.
Okay. That's really interesting. Now, I know, Angelyth, you also have a YouTube channel
Yes, we do.
that talks about these things as well. So let's talk a little bit about that to help with maybe the caregiver guilt we're talking about, the myths that we're talking about.
Yes. So with our YouTube channel, like the idea started that there are some people that do not like to read, that they're more visual, or they love listening to podcasts or music. So we figure, okay, what if we shift the focus and do some short videos on what is hospice, explaining like the dying process, what are the benefits, what we provide, what is the main team, and what are their functions. So it has been very productive to send that to families, because it's also demystifying the hospice word, that it's like the fear, taking the fear away, like making sure that they feel comfortable. So it's been wonderful for families to actually being able to see those videos, and they're not so long, so we keep the attention focus on like our people.
What's the name of the channel?
So it's Hearthstone Hospice, and we are in YouTube.
Okay, wonderful. So we've gone through this journey of talking together. We've established a lot of different facts to help people feel more comfortable. So when a caregiver is taking care of a person in the adult foster care home that's on hospice, what does that look like, and how does that change what the normal routine would have been before hospice?
So I say for my caregivers, when we're taking care of a hospice patient, we have to view it a little bit different. And in the sense of like, we're gonna be getting more things to be able to take care of this patient. And by things, I mean, like we're gonna be getting the right equipment for not hurt ourselves while taking care of the patient, whether that it's a Hoyer lift, a hospital bed, a walker. In our case, we give the group homes a recliner, so they're able to still go out in the living room. Also, all the incontinence care supplies that the hospice provides. So you're not going to be short hands trying to look for supplies here and there. Hospice is going to be sending all of those supplies that they need, whether it's brief, pads, pull-ups, all the ointments to prevent skin breakdown.
Again, for free. This is all part of the
and
Medicaid
that's
benefit.
covered. Yes,
Yep.
That's
yes.
amazing.
And then when they develop wounds, like hospice will also cover the wound care supplies that they need for those to address those wounds. But the most important thing, this is very important, but like the most important thing is the core team. So they're gonna have a nurse available 24/7 on call, and then they're gonna have a nurse that is gonna be coming to do those routine visits. And they can increase or even decrease as often as the patient needs it. So if the patient is having respiration issues or if having frequent anxiety, those visits can increase. Also the social worker, like the social worker plays an important role within the family situations, because there are family dynamics involved in this. When there are more than 1 or 2 or 3 kids, then that can become a little challenging, because one can be in one mindset, the other one can be in a totally different
100%.
mindset. So it's just bringing the family together. That's what the hospice team pretty much does. So that takes that stress off, the stress off the family members, but the caregivers. Like the caregivers get so stressed out by all of those family dynamics, they're fighting or they're arguing or just not being in the same agreement. So that's what hospice does, pretty much like help guide and ease off that tension. Another thing that they love about hospice is that they get a hospice aide. So that also helps and relieves some of that workload that the caregiver would have, because the hospice aide is going to be coming to assist with showers or even just to sit down with the resident and help feed the resident.
So hospice is not there to be on site 24/7 like the other caregivers. What is kind of a cadence that
So
someone could
the protocol would be hospice is available 24/7 on call. So if something happens and then you need a nurse, you have a nurse available that will go to the house or to the group home or assisted living whenever there is a situation happening. So they're going to be able to address the situation, whether it is over the phone, if it's something that can be addressed over the phone, or if a visit is needed, then they're going to come and do a visit for you.
Yeah, we try to stagger visits throughout the week. So, you have the nurse, the case manager, and then we also have LPNs that usually will come like every week or every other week. The social worker, so that person.
The chaplain.
Yep.
Chaplain.
We also have the chaplain. And then a lot of people don't know, but Medicare, one of the Medicare requirements is that 5% of your census has a volunteer assigned.
Yeah.
So we are constantly looking for hospice volunteers. But that volunteer piece is so important. It's a companionship volunteer. So we also have a We Honor Veterans program where we have veteran to veteran volunteers. And that is kind of something that you climb the ranks, they call it, and you can go up to like a 5-star. But a lot of veterans only feel comfortable sharing at the end of life with another veteran. So that is also, you can do, like I said, companionship. That is another really big piece. And so we try to kind of, we create a calendar and kind of stagger those visits throughout the week.
So there is
they're
always
getting
enough
some-
people covering and seeing the patient.
Getting a
as
little support at least.
Yeah,
every
and
day.
I heard and I've seen that by having all of those visits and interactions, that also helps prolong life, because
Yes.
when somebody is alone, not having interactions, like we're humans, we're social beings, that helps the patients, or what we call residents, like prolong life as well. So
Absolutely.
Yeah.
Yep.
Do most of your patients, do you call them patients?
We do.
Yes.
Yeah.
Okay. Do most of them want the other residents in the home to feel free to visit? Do they want privacy? Do they want the caregiver to keep in touch with them, or would they rather have you take care of them?
that will vary. Like each patient or resident in the group homes are different. There are some that want privacy and that they decline services like Chaplain or social work or even the hospice aide, and they just want the nurse to be handling the case and communicating with the caregiver.
Okay.
But there are other residents or patients that absolutely love having all of those interactions. So they really, really take advantage and benefit from all of the visit and the interactions. And some other hospice, like our hospice, they do provide music therapy and pet therapy. So that's something that adds on to that interaction with the residents. And I know there's some hospices that also do that. So it's a wonderful thing
And
for them.
I found that a lot of, like sometimes, in the very beginning, people are a little bit leery of having all those people come. But then they're like, nope,
Bring them in.
on. Yeah. Yep.
Like now I'm loving the attention.
Yep.
Because
Yep.
they get comfortable and yes, they get to love the attention. So that's a very important one. Yeah.
I understand the military connection. We've seen that with other residents in our homes where they can open up to each other. They have
Yes.
some sort of a bond
Yes.
that we wouldn't have with them if we hadn't served.
Absolutely.
Well, let's go through the steps then. We've gone over all of the basics of like 1, 2, and 3. So number 1, from what I gather, is we're noticing signs and symptoms. And you brought some great handouts, Maria, which
Yeah.
will provide to people that will list
Yeah.
what some of these things are.
Yep, absolutely. For us, we have a palliative care program that is nurse practitioner driven, and it's a model that it's not widely used, but it's kind of what we've always done since we were Hospice of North Ottawa. We've always had this nurse practitioner driven palliative program where we actually go out and see patients once a month. A lot of other, I don't know if you guys have a palliative program, but
Not at
because
this
it's
point.
not,
Yeah.
it's not, like I said, it's kind of a diamond in the rough actually, because some other programs, they do like a lot of phone calls and it's more social work driven. Like, let's get your advanced directives, what do you
Right.
want, those kinds of things. But we do a lot of symptom management and we actually prescribe medications. So that's kind of out of the norm. But
Yep.
with that palliative care program, I would suggest to kind of, look around in your community and just kind of, ask questions. If you have people that are stopping in and marketing, that's a good question to ask is, if you have a palliative care program or not. But palliative care, it looks a lot like hospice, but these are for people that are still seeking aggressive treatment.
Right.
So people that are still continuing chemotherapy or radiation, they still want to go to the hospital.
And that they also want physical therapy
Yep.
and occupational therapy.
Yep, we
and all
can
of that.
go in jointly with
All right.
PT, OT, those kinds of things. But there's someone that is having uncontrolled symptoms, like nausea, like cancer patients, nausea, fatigue, anxiety, depression. All of those things can help, with palliative care. And this kind of goes into a little bit more in detail some of the things that palliative care can help with. For hospice, we have a different, it's kind of like this, there's a lot of similarities. But again, hospice is for people that no longer wish to go to the hospital. They are not seeking any aggressive treatment and they want to focus only on comfort and quality of life.
Okay, can we stop there for a second? Because sometimes dialysis is,
Yes.
I hear sometimes that does fall under hospice, sometimes it doesn't qualify. So let's talk about that real quick.
So we will continue dialysis if the patient's hospice diagnosis is unrelated to the kidney failure. So in cases like a lot of times it comes down to the cancer patients where they have, like lung cancer or, something that is not kidney and they've been on dialysis for years and now they have, lung cancer. They can still continue dialysis while being on hospice for lung cancer. It's kind of like a dual diagnosis, we call it. And there are other ways that you can also be at home doing peritoneal, like your own dialysis. Yes. It's not cut and dry.
Okay.
That is one area that is kind of gray, and I have found that it's up to your own medical director, whoever your physician is.
That's right.
Because they are the ones that are ultimately responsible for Medicare either paying for it or not paying for it. It's not that hospice wants to stop anyone from seeking that treatment, but Medicare will only pay for it if it's not related to the hospice diagnosis.
Interesting.
It is. It can get kind of sticky.
It gets tricky.
So step 1 is noticing the signs and symptoms. Step 2 then would be to call your organizations for an actual consult.
Consult, yep, and evaluation. And as she mentioned, like we don't need an order for us to go and do an evaluation and see if the patient is appropriate.
Or a lot of times people just want an informational visit.
Yes.
And I think that's a great way to put it to families and residents is why don't we just listen to what they have to say, and then hopefully we can kind of dispel,
guide you through this.
dispel the myths
Yes.
and, help you guys understand what hospice really can do.
And what's the difference also between palliative? Because another thing that I notice is that families even though they are on hospice and even when they sign up their loved one on hospice, they don't want to call it hospice.
Yes.
They want to call it comfort care, palliative care. They want to put so many different names because they're afraid of the word.
Yep.
And that's something that we just have to keep working on. This may find the hospice word.
Yep.
Good point.
Absolutely.
Yeah.
Is this, I imagine daughter number 1 might want one thing, and daughter number 2 might want another thing, and then the son has a whole different idea. Is this an a la carte type menu, or do you have to educate them to the point that you're in control?
Depends on who the decision maker is.
Yes. That's what
Because
I was
ultimately, if it's the patient and if that's what they want, it doesn't matter what the kids
saying.
say.
The kids say.
Got it.
And sometimes it's one of the kids that makes the decision and the other ones have to go along with. But what the hospice does is that they sit down with those 2 kids that are not in agreement, or they meet them where they are to bring them to the full understanding on what we truly are and how we're helping, and show them this is what we're doing, this is how we're helping, and this is how it's helping your loved ones.
You could go to the UN with that talent.
Well, and
that's
actually,
amazing.
that probably is really beneficial for the caregivers, although they have no decision-making role as it relates to going on hospice or not. The same questions might be present in their
Oh,
mind.
for sure.
Yes, and most of the times the caregivers start noticing the decline, and they're the ones that open the conversation with the family members. Most of the times they refer to the caregiver managers or AFC owners, and they let us know, hey, I see that this person is stopped eating, or something's really off, but I cannot fully identify what it is. Can you help us? And then they're the ones that bring out the topic of like, oh, but I remember when so-and-so was having the same symptoms, they got in hospice and they started taking care of this patient, and it was so helpful. So most of the times, the one that truly see the decline and that bring up the topic, it's going to be the caregivers. So the caregivers are the ones that we need to educate the most, so they can see the early signs, so they can get on hospice early, so the patients can potentially live on longer and those symptoms can be managed. That's how we approach
Absolutely.
the caregivers.
Yep.
And interestingly enough, too, licensing also views a hospice patient differently too, because when they're receiving those services, they know they're in a state of eventually passing within a shorter period of time than someone not on hospice. So if that person passes, then they're not going to trigger an investigation,
Yes, that's correct.
which would normally happen
Yep.
with someone passing without being on hospice. And that's something that a lot of AFC owners don't even know about.
And that's a very good point,
Yeah.
because depends on the county. Like for example, in Macomb County, if a resident passes away under hospice care, the police is not required to go and do an investigation.
Yeah.
In the case of Oakland County, even though the patient is on hospice, most of the times the police has to be notified that it was a hospice case. But when they're not on hospice and for some reason things are not aligned, where they don't have the power, like the power of attorney and the direct advantage.
Advanced directive.
I'm sorry.
Yeah.
The advanced directives like set up in their full code. Even though they have passed away and you know that they're gone, they're gonna do a full code on the patient, and that can be very traumatic for the caregivers,
Absolutely.
and of course for the patient that has passed away. Like, it's very traumatic. So
Yeah, on the west side, if they're on hospice, they just call us and we pronounce time of death. That's the same for, like I said, all of West Michigan. But if not, then the medical examiner, the medical examiner has to be called
Yes.
to investigate.
Yeah.
The caregivers, up until this point where somebody is eligible for hospice, they've invested a lot in these people quite often. Sometimes a patient comes to them ready for hospice, but sometimes they're very connected and they want to continue caring as much as they can. And it sounds like you want that.
Absolutely.
Sounds like you want to work with them on that.
Yes.
Because they ultimately will be the people that are there, doing the day-to-day things. Most of the time they become bedbound, and that's a tremendous amount of care.
Yes.
So they are still the ones that will be providing that very intimate care at the end of life.
Yeah, and that's why it's important educating the caregivers on the early onsets, because once hospice is in, and if you have like 6 months on hospice, like caregivers can be educated because the nurse is going to be coming as frequent as the care plan is set up. But they're going to be bringing that education and preparing you and educating you in medication. You don't have to be a nurse. You don't have to be a CNA to know about like what those medications are for and how to properly use it. But if the patient gets signed up just for the last week, like hospice
Right.
really doesn't have enough
We don't have
time,
time,
to
yeah.
teach and to show what actually we can do for them. So it's very important.
Yep. I think that the work of each AFC is so important. And kind of maybe like one of the things that I'm thinking in my experience that we've had within the last year is that there are sometimes, people with cognitive or physical disabilities that their lifespan is shorter than normal. And so we have, had those younger patients on hospice. And I've seen the toll that it takes on those AFC caregivers.
Yes.
And we know that, we want to support you. And again, anything that we can do.
And that's part of the bereavement process too. So hospice has also a bereavement program that after a patient passes away, then it provides that support to family members and even caregivers that are going through the grief process. So they will be contacting them and showing up for any support that they will need.
For 13 months.
For 13 months.
Wow.
Yeah. Yeah.
What
And
a
it's a
wonderful
wonderful
benefit.
program. Yeah.
And they don't have to have been specifically on our hospice either. Like we will help anyone with grief counseling.
Yeah.
In our homes, we had caregivers who were excellent at helping their residents transition when somebody died to cope to the best of their ability. Each resident has a different ability. I guess we all do. And you talk about an end-of-life service that you actually perform in the home for the residents. What is that like?
Well, we've done things where we bring in a chaplain, our hospice chaplain, usually the case manager, maybe social work, and we just kind of, do something special to remember that resident. One that comes to my mind is a former nurse. And we did the whole Florence Nightingale tribute with the lamp. So we have a lamp that we bring around. But I think, Angie, you had some other things too that you guys do.
Yeah, so in our group homes and with our hospice, we have put together a memorial service where we do the candlelight ceremony. So we will light a candle for each resident that had passed away within that home. And we have done that because we noticed that the residents were also going through the grief of losing their fellow friend and roommate pretty much, that they are sharing a home. So it's that emptiness and not being able to get that closure. So we started doing this memorial candlelight ceremonies, and that brings the chaplain, and then the social worker, and then we do the whole candle lighting. We print a picture of each particular resident that had passed away. We invite family members, and we make a beautiful ceremony for them.
What a great way to help them with clothes, especially if they're not able to go to a funeral, if there is a funeral.
Exactly.
Yes, exactly. So it's a good way to bring the funeral without bringing the funeral to the home.
Yep.
And it's probably a good way to close our show then. I think it was an excellent discussion. I learned a lot. I'm always impressed with how organized and how professional hospice is. They take care of so many details that people would not even consider. And they're good at it. They're highly trained. Both of you seem to be highly trained and professional and caring, which just goes with caregiving. Of course, our Mastermind members can continue this discussion in their own community through their membership with other AFC owners and managers. It's an exclusive community for you. So you can teach each other, learn from each other, and of course ask questions for Nadine to answer for you. Thanks for watching, and thank you both, Maria and Angelyth, for your help in understanding this topic.
Thank you.
Anytime.
I think it'll help our caregivers and our owners as well as anyone else that watches this. This video could be very useful to many people.
Absolutely.
So our hope here at Care Provider Solutions is that you constantly rekindle the passion you have for caregiving, that you don't let either the lack of knowledge or stress, burnout, ruin that for you. When you have help, Nadine's always here to help, and other friends of ours come along to help as well. So make use of that and keep up the fight. Thanks for watching.